Okay, so good afternoon, everybody. Can you hear me? Debbie, can you hear me? Sandra, great. Okay. Um, my name is Raul Ulises Hernandez Ramirez, and I'm a research scientist at the Yale School of Public Health and the Center for Methods, Implementation, and Prevention Science, and core director of the Dissemination and Implementation Science Methods, DISM core of the Center for Interdisciplinary Research on AIDS, CIRA. And thank you for joining us for today's webinar. This webinar is co-sponsored by the DISM core and the Ready Hub, which stands for the Rigorous, Rapid, and Relevant Evidence Adaptation Implementation to Ending the HIV Epidemic Implementation Science Hub, as well as the Center for Method Implementation and Prevention Science. The DISM core provides expertise in methodological consultation, technical assistance, grants, peer review, trainings, and seminars, and participated developing and applying innovative research methods and assessing CIRA's impact. And the Ready Hub provides technical assistance to ending the HIV epidemic projects and other HIV researchers and implementers, and collaborates with a network of hubs with the goal of creating opportunities to translate local knowledge into generalizable knowledge whenever possible. And now I'll pass it to Dr. Debbie Humphries, who will introduce today's speaker and facilitate the discussion. Thank you.
Thank you, Raul. We're very excited that Sandy's able to come and share a little bit more about the arc of of the research that she's done over a number of years, really building up to some culminating work with mobile health clinics. And Sandy is a professor of medicine in the Department of Internal Medicine at the Yale School of Medicine. She's also board certified in internal medicine, infectious disease, and addiction medicine, which speaks to the interacting and complexity of the fields that she has been working in. She's been appointed to the National Academies of Sciences, Engineering and Medicine's Committee on the Framework for Consideration of Chronic Conditions in Women, and to the Committee on the Examination of the Integration of Opioid and Infectious Disease Prevention Efforts in Select Programs, which really speaks to the work that she has been doing in integrating substance use and infectious disease with a focus on opioid use disorder and the treatment and prevention of HIV infection. With that, I'm going to turn it over to Sandy. She's got her slides ready to go. And we encourage you as we go to put questions in the chat. And Sandy, I don't know if you have a preference for saving those to the end or taking them as they come.
If you don't mind saving them to the end, that would help me.
Great.
Okay. But yeah, just feel free to jot them down as they come. It's just easier for me because then if that's okay with you.
That's fine. And I'll just monitor the chat and I won't interrupt you till we get to the end.
All right. Thank you. So yeah, thanks for the introduction. And we were I was previously invited to another talk, and I think subsequent, as you were saying, to that was asked to come back, and I really appreciate it. So these are my disclosures. And I also want to fully disclose, I am not an implementation scientist, but I do work with them. So I'm really hoping that as I talk a little bit about some of the work we've been doing, really thinking about collaborations and areas where there could be more synergy, especially here in Connecticut, but also more broadly speaking. So, our research program is called InStride, which is Integrating Substance Use Treatment and Infectious Disease for Everyone, and it's fully funded by the NIH. My research started funding from NIH in 2005 with my K23 award, and then continuously funded up through now, through 2029, fingers crossed. And it's really been at that intersection, as you were talking about, of integrating substance use and mainly opioid use disorder treatment and interventions, as well as infectious disease, mainly HIV prevention and treatment. And that spans bench kind of collaborations with immunologists and scientists, including HIV, as well as hospital settings, carceral settings, and the community-based delivery of care. I previously talked about one of the NIDA EHE implementation effectiveness trials. So I won't really be focusing too much about that, and really emphasizing some of the work we've been using more with mobile health interventions. So I'd first like to thank my awesome InStride research and clinical team. I think they're pretty much all here, and they just won an ARC award from that was given to them by the dean for their amazing community outreach. I think pretty much everyone's there, including I wanted to point out Cindy Frank, who is a director of our program, who she doesn't like to be in photos, so I'm just emphasizing they all look good. So why I think this was, why do I even think about this, and why are we moving to that? As it's already, you guys already know this, you're already doing this work, but let's just emphasize it. There's a lot of barriers to accessing our traditional healthcare system, including HIV prevention, treatment, and substance use disorder services. I'm a clinician, as you said, so I saw this and I see this, but also from a research perspective, we also see this. So there's lack of transportation, including in Connecticut. We don't have a public health, public transportation system really for spanning our state. We have housing instability, poverty, lack of insurance can be an issue. Obviously, lack of a personal form of identification, comorbid mental illness, pharmacy services, which I'm really going to emphasize, not just physically, finding a pharmacy, but even if there's a pharmacy there, really access to the medications. Do they stock the medications? What are the co-pays, other restrictions? We cannot emphasize enough the stigma across all settings, community healthcare and pharmacy settings, which are really substantial, and just this overwhelming identification and how to really navigate all of this. We know that substance use disorders and substance use are highly prevalent in the United States. Predominantly what's driving, unfortunately, our epidemic of overdose deaths are synthetic opioids, mainly fentanyl, but other synthetic opioids and stimulants on their own or in a combination. I also want to put a shout out that we can't forget alcohol, which is significantly causing a substantial amount of harm. So I have done research in that area, and I just was going to emphasize mainly opioids in this talk. We have had some good news, as y'all know, about drops in overdose deaths through December of 2024. There are certain states that are doing a better job in seeing that compared to other states. But we all know this, right? That there's a lot of communities that are not experiencing the same reductions. This is just data from Connecticut. In the middle there, the dark orange represents non-Hispanic Black populations who self-identify in that race, ethnicity. There was, from 2021 to 2022, an increase in overdose deaths. And then there was a slight drop, but it's really not at the proportion that we're seeing in non-Hispanic white population. So really emphasizing that, not everybody's receiving the same benefit. And we know across the country that there's a lot of populations that are not receiving, we're not seeing the same benefits. However, it's not like I'm downplaying the amazingness with our drop in our overdose deaths. It's just that I'm not completely convinced. That's all I have to say. And we really need to keep pushing and doing better. So this is older data, but just as my emphasis point, right, of why I do this, preceding the earlier outbreak of HIV occurring among people who were injecting a prescription opioid, oxymorphone, in Scott County, Indiana. Prior to that, we'd seen great strides in reducing HIV among people mainly who are injecting drugs through the syringe service programs, methadone expansion, obviously the Ryan White Care Act, and medication treatments for antiretroviral therapy. But since that time, there was and that was a non-Medicaid expansion state, as we know, syringe services were not allowed, and there was a moratorium on really expansion of methadone programs. But since that time, and again, this is not complete, there was multiple outbreaks occurring among people who were injecting and using not just injecting, but fentanyl, heroin, methamphetamine, cocaine, and not just through injection drug use, but also through condomless sexual intercourse in Medicaid states, in those who even had really substantial services. So we knew people weren't really getting access to this, the PrEP and other services and other treatments. So our goal, as you know, for those who live with HIV is to achieve viral suppression, obviously reduce morbidity for the individual, but also from a public health standpoint, reducing transmission. So we really want to help people who have HIV get into care, get on medications, and stay on medications. And we know that ongoing substance use increases not just risk for acquiring HIV, but also interferes with that HIV care continuum. And so when we think about integrating care, and this is kind of what my formative early work, starting with my K23 20 years ago, and onward, was kind of this idea, okay, we need to provide medications for opioid use disorder and alcohol use disorder to people who have HIV to improve the likelihood of achieving viral suppression. And, you know, that we've done that. And sure, it shows that, and the idea that we can treat a substance use disorder and have this distal other outcome beyond improving substance use outcomes that could improve not only health for the individual living with HIV, but from a public health standpoint, could potentially reduce transmission. That being said, you know, and this is where we get into implementation, right? We have a wonderful EHE plan supported by years of evidence-based science. We test everybody. It's not just once, but think about multiple times. Treat everybody rapidly with antiretroviral therapy, includes the same day. Get them on virally suppressed and maintain viral suppression. Prevent, meaning get everybody who does not have HIV at risk for HIV on PrEP. And now, yay, we have 4 FDA-approved medications, including long-acting lenacapavir every 6 months as of June 19th, and also syringe services. And then to predict and respond and reduce HIV and to be able to get there before we see new outbreaks. But it didn't really include implementation plans and certainly did not include identification and treatment of substance use disorder. So sadly, while we had been seeing a 12% reduction in new HIV cases in the United States, we've now seen, well, as of the data of 2022, a 5% increase. So we're not on track to get down to 9,500 cases by this year, certainly not. And when we look among the population who identified as injecting drug use, we are seeing we are far from the mark of getting to 100% viral suppression, which is what you need, right, to achieve that distal public health and outcome of maintaining viral suppression among our population that is reporting injection drug use. So when we think about why it's not working, why isn't this wonderful plan working? It's not working for everybody. It's certainly working for some populations. I'm focusing on people who use drugs, but we really kind of expect people to know where to go to get testing, go somewhere to get PrEP, somewhere else to get substance use disorder treatment if they want that, harm reduction services, and really haven't asked why. And, you know, how can we help populations really access services that are in an integrated fashion, and how to change our delivery healthcare system. When we think about people with HIV, you know, definitely Ryan White care programs have been just outstanding for the most part in providing those wraparound services. However, they're not all created equal, right? We know not all of them are providing MOUD and other services. So it's not just those who don't have HIV. We have to think about our population that has HIV, and also thinking about it's sometimes very difficult for people to come to a clinic and to stay in a traditional healthcare system. We've had some advances, as I was just mentioning, long-acting PrEP, ART, but also MOUD. And these are some of the areas that I've been focusing on is, could these potentially interventions we know are very effective, can we figure out, could these be really helpful in retaining people in care? So we have 3 FDA-approved formulations of long-acting medication treatments for opioid use disorder now. all available in Connecticut. Vivitrol, which is an extended release naltrexone, opioid antagonist, also treats alcohol use disorder, and then 2 forms of long-acting buprenorphine. And so there are, pros and cons for most, but the long-acting buprenorphine products are most of interest because they can treat. You can help people who have comorbid pain, who might have also might be in withdrawal, while naltrexone, of course, you can't do that for those. We also, as I'd mentioned, have long-acting PrEP now with cabotegravir, but also lenacapavir, which should be coming soon. It's now approved, and long-acting antiretroviral therapy. And there's been, a lot of people who've shown that persons who use drugs, though, are not really getting access to some of these longer acting treatments that could be really beneficial to them. However, there's been recent guidance from a group that I'm a part of, the International AIDS Society USA Guideline Committee, indicating we should be thinking about how to provide some of these medications like long-acting antiretroviral therapy, CAB, rilpivirine, traditionally thought, oh, we can only use that if they're virally suppressed, more towards helping individuals who are having adherence challenges to get onto those medications, as Monica Gandhi and others have indicated, in populations who are unhoused in San Francisco. And then there's a new guidance out also by IAS USA last week, I think, in JAMA for PrEP, long-acting PrEP for populations that are having difficulty. So yeah, some of the populations I've been really focusing on are criminal legal involved persons since the beginning of my career. And this is a population who has, as we all know, higher rates of substance use disorders and at risk for HIV. And then that period after release is very chaotic. And we know that even though people can achieve viral suppression who have HIV, can be quickly lost. There's a lot of reasons for that, including potentially recurrence to substance use. And as I previously mentioned, we've shown that if you can provide treatment to prevent relapse before people get released for opioid and an alcohol use disorder, not only can you improve those outcomes, but you can also improve viral suppression rates. We also now have a current trial comparing long-acting naltrexone to long-acting buprenorphine as a NIDA-funded JCOIN study that completed in the primary outcome. We should be out next month. We're just cleaning the data. And one of the sites was Connecticut for that. So comparing 2 long-acting different formulations of treatment. We also have looked at hospitalized patients. So we know in our hospital settings, it's a reachable moment to be diagnosing substance use disorders, also identifying people who are at risk for HIV, other co-infections, hepatitis C. And we just completed a trial that was just published a month ago that initiated long-acting buprenorphine in patients who were hospitalized with infections. Although we didn't see a statistically significant difference between those who are in the treatment as usual arm, I think a really important point was almost 60% were on a form of MOUD post-release, which is quite amazing. And in that intervention, we included a nurse care management model for everybody because we wanted everybody to have something. And that probably diminished the difference between the 2 treatment arms. But again, that's something that should be explored more. But there's also less overdose deaths in that population that got long-acting buprenorphine. So this idea of providing a long-acting form of treatment similar to in prison and jail prior to release from discharge from hospital could be a protective opportunity as well. We also published on this missed opportunity where people weren't offered PrEP. Majority did not have HIV, and they all reported high risk behavior. This included Yale New Haven Hospital as one of the hospital settings. And so this reachable moment where as providers, we should be thinking about providing prevention opportunities in these settings. And I have to also mention almost 50% had detectable hepatitis C viral load, and no one was offered hepatitis C treatment. So another reachable moment that, we need to do better at. Veterans, I'm a VA doctor as well, and this population, as we know, has a substantially higher level of opioid use disorder, other substance use disorders, and overdose events. And so we are, with Ismini Petrakis, who's here at Yale, conducting a large trial nationally comparing injectable buprenorphine to sublingual buprenorphine in a real world effectiveness evaluation to see if one's better at retaining on other, and also looking at infectious disease outcomes. And that one's ongoing. I think this is where I get to, these are all lovely, right? We love randomized control trials. They're touted as, especially double-blind placebo-controlled trials, as a gold standard. But, something I've always thought about is what's done in research. We should be really providing for routine clinical care. And Charlie Flexner at Croy a couple years ago quoted himself from many years before saying, people don't fail drugs and drugs fail people. And I jotted it down and I was like, yes, this is absolutely true. We need to do a better job if we see these drugs are effective at trying to get these medications to people. And it's messy, but if we can do it in research, why can't we really do this in clinical care? And that means helping with transportation, right? Helping with people to get access to reminders to their research visits, other things that we provide. So we've been really working at more, which is the title of this talk, and how to overcome some of these barriers by bringing services to people where they live. So mobile health interventions. And this started out with simply a NIDA-funded UO1, and they specifically asked in their RFA, compare a mobile health unit provision of care to a personal linkage facilitator, peer patient navigator. So it wasn't like I had this wonderful idea. It was like in the RFA, so to compare it. And I was like, oh yeah, well that would be a great idea. And the idea was to evaluate, is one of these linkage models better at providing HIV prevention and treatment along with substance use disorder services? And the specific one asked for us to evaluate all the care cascades. So substance use, PrEP, HIV, hepatitis C, and STIs. So it was a large trial, and we're conducting this in Texas as well as Connecticut, which I think is very important from implementation standpoint. Uh, so this is a type 1 implementation effectiveness trial where we're really comparing these two interventions, getting these quantitative outcomes as well as implementation outcomes, really assessing the acceptability, barriers, feasibility, and costs for both interventions. We use the EPIS framework. Our colleagues at TCU, Kevin Knight, Jenny Beacon, et cetera, are the experts in this area. And we're working with cost with the NIDA-funded Cherish Center as well. This is the fancy design trial. We've already completed our recruitment. We have over 601 individuals, and they're followed for 12 months, a 6-month intervention randomized to a patient navigator who literally brings you to any of the appointments that you need in the area you live. Typically brick and mortar clinics, not to the mobile health unit. And then the mobile health unit, which provides a one-stop shop, including clinical care, as well as a community healthcare worker to help with social needs. And then along this whole trial are the implementation assessments that are occurring. So we have the final 6-month outcome will be completed this month, and then we'll have our last 12-month sustainment period in October. These are obvious differences. We purposely, although I love my colleagues at TCU and UT Southwestern, I think we really thought about this. Hey, if we're going to do this trial, let's look at Connecticut, Medicaid expansion state, Texas, non-Medicaid expansion state. We want real world understanding about access to services in these two very different states. They also have very significant differences in the type of criminal justice system, types of drugs that are more available, methamphetamine in Texas, cocaine here. And then syringe services are illegal in Texas and legal in Connecticut. So we provide services for all of these things. Although the primary outcome is an HIV prevention and treatment outcome and substance use disorder, we felt it was really important that everybody could have access to social needs, housing services, cell phone, form of ID, harm reduction services. We also do rapid STI testing, bacterial STI testing, Hep B, along with Hep C and HIV testing. And the patient navigator links you to all those things in the community, and the mobile health unit provides those on the unit. These are what some of them look like. And we had 609, but now down to 601. 8 of them were not able to, were removed from the trial, but you can see the demographics here. And just to point out, a majority are unstably housed. And I think the other important point is, which we know, and I know this as an HIV provider, and you guys know this, what we perceive an individual's risk being may not be the same as what the individual perceives. And so this is really important. So the majority don't have HIV in this trial. They could have HIV or be at risk for HIV and had to be also, if so, eligible for PrEP. So just to remind you of all that. And sure enough, the majority didn't have HIV. And for STI testing or STI in the past, about a quarter had STIs. And then we do individualized risk behavior assessment from sex and injection drug use at baseline as well, and prospectively. And the majority had significant risk behaviors. Remember, they were also all PrEP eligible, but did not perceive themselves at risk for HIV. So this is really important when we think about, providing interventions for PrEP. First is really understanding what people think, and then education, and then ongoing potential opportunities to help patients get access to treatments if they want them, and prevention. The other important point that we learned, and we did a very in-depth needs assessment at baseline for all participants, and I highlighted Texas and Connecticut, and you can see there's a lot of similarities, right, in the needs, which is important. What people wanted, again, criminally legal involved persons who use opioids and or stimulants at risk or living with HIV. And those other needs are very supersede the biomedical needs like MOUD, PrEP. And then other needs are incredibly important, a form of ID and cell phones. Almost half didn't have them. So thinking about when you're going to make appointments for people or want them to come back, if they don't have a way to communicate, how are you going to do that? And then, of course, you can see the other barriers like housing and food, transportation. So when we're thinking about devising interventions and our implementation strategies, we have to really be taking these into considerations. And again, this is not the standard clean randomized control trial, right? Is really understanding what people want. And this is why implementation science research is so important. And shared decision-making, patient choice is essential. So, this is what would be ideal, right? You ask people what they want and you provide it. You ask where they want to receive it, and you bring it to them where they want it. But we can't always do that. But we try to. I just wanted to show you some baseline data from this trial. So we asked everybody, right? They all had to be eligible for PrEP if they did not have HIV to be enrolled in the trial. But it's important to know that 61% were not interested at PrEP at baseline. 33% were. And then if you ask them what type of PrEP they would like, long-acting injectable or oral, the majority wanted long-acting injectable. And oftentimes I say this in my clinic when I talk to residents and others, don't forget to ask about sex. People who use drugs have sex too. And although injectable PrEP may not be FDA approved for injection drug use risk, it is for sex. So, and this is a medication that people do want. And this is just a small snippet of those who are randomized to the mobile health unit only in Connecticut. When we go down to those who are interested in PrEP, again, at baseline, the majority wanted long-acting injectable. When we look at some of the experiences of the patient navigators and the community health workers in this trial, I think this is also important. And what I'd heard on the prior implementation EHE webinar that we gave is really understanding the patient navigator and community health workers experience. Unfortunately, my slideshow just froze. So I'll just have to, oh, there we go. Phew. Can you guys still see that? Or okay. Can you see that?
Yes.
Yes.
Okay. So I just wanted to point out some quotes from the community healthcare worker. This is in Dallas. You know, this idea that they actually were able to help somebody get through hepatitis C treatment and get onto buprenorphine. That was a bonus. Oops. And then in Tarrant County, which is at Fort Worth, some of the barriers are, you know, organizations when you're trying to connect people as a navigator, community healthcare worker. Sometimes they go in and out, and they're not always available, or things change, and so that can be really difficult. And then from a mobile health unit provision, you know, our mobile health units for this go to literally where they live. So if you're unhoused, they would drive to the encampment. If you had a halfway house, they would drive to the halfway house. They would go to where people wanted them. They wouldn't just stay in a fixed location. But an important barrier is hours, right? And so some people would want to access the mobile health unit, and it might not be available. So that was a barrier. And I could go on for other quotes, but you know, there were things that we've learned that are really good: building trust, having mobility and flexibility, able to troubleshoot, being available are really great things about PNs and CHWs. And then there's just a lot of challenges, right? This really difficulty sometimes in contacting participants, even when you provide them a cell phone. There's a substantial high recidivism rate in Connecticut as well as in Texas. Um, and, you know, PrEP is not a priority. And I think the other big thing, and I say this and I talk to NIDA project officers a lot about this, is that, you know, the funding is usually very limited. So therefore, you can't extend your intervention. Really, it's typically a 6, maybe a 12-month intervention. And we see that people, sometimes it takes them about 3 months to just really get to the point where maybe we can start talking about PrEP or MOUD, and the intervention's halfway done. This is the other trial I already talked to you about, which is really looking at a shared decision-making intervention. It's EHE dollars from NIDA, and it's being conducted in Texas, Connecticut, and Kentucky. And we're doing a type 3 implementation trial comparing the patient navigator with a patient choice menu of options, which is really targeted on however they want to get services and what they want, including mobile health, plus patient, you know, navigator. So really everything compared to traditional patient navigator services. So that one is just starting the R33, which was provided in May. We finished our pilot last year, and I won't go through that because I talked about that before. The big thing, though, of everything is you can do all of this, but if you don't, and say you do get somebody who's interested in treatment, and this could be anything, right? High blood pressure, you know, antihypertensive, diabetes medication, you finally have a reachable moment. For us, it's like PrEP, ART, MOUD. If we can't bring the medications or get them the medications, then we're really not making too much of a difference. Like people really in the moment, especially for opioid use disorder, getting them treatment when they want it in the moment is absolutely critical. And when we're thinking about the EHE pillars, rapid antiretroviral therapy means same day, point of care HIV testing done, rapid PrEP. So this was the next step, which is what I really have been focusing on, which is creating and providing that, and not through drug company investigator initiated trials, like real world. We often hear, though, and I still get this quoted to me, why do you care about this? There's pharmacies everywhere. And the quote is, over 90% of Americans live within 5 miles of a community pharmacy, which is often quoted in papers. 5 miles, if this is true, is a substantial distance for many people. But even if you can get to a pharmacy, or there are pharmacies maybe in your area, we're seeing tremendous amounts of pharmacies being closed, including in Connecticut, including the sheer large chains, Rite Aid, Walgreens. And then when you can get there, there's a lot of medication gaps. So we talked to multiple pharmacies in the Waterbury, Connecticut area, and the majority didn't even have Suboxone, buprenorphine, because they said they quote unquote do not see those people. So you might not have the ability to get a prescription, even in Connecticut. And I think this is really important to know. Or let's talk about long-acting PrEP, or long-acting buprenorphine, or long-acting antiretroviral therapy. Those are dispensed in specialty pharmacies, and many of our community pharmacies are not considered specialty pharmacies. The logistics, like a person who's unhoused, it may not want to walk 2 blocks or go even a block too, because you have to leave your belongings and there's potential for them being taken away. Stigma, just think about when you go into a pharmacy, you have to say your name and you have to say the name of the medication. There's not really substantial privacy layouts, and there's a lot of requirements, including types of wearing shoes, which some patients may not have. Administrative hurdles, there's some pharmacies that require an ID. Obviously, insurance and co-payments are substantial. And then there's really no navigator services in pharmacies to really help you overcome those challenges. So really, in addition to our healthcare system, our brick and mortar pharmacies are really not adequately designed or equipped to reach this population. So what we tried to do, it's not rocket science, was put together a mobile health unit with a retail pharmacy, so that you could get access to everything, whole person healthcare, if you wanted it. Non-stigmatizing. It's not a mobile methadone program. It's not a harm reduction program. All great. I'm not saying there's anything wrong with them, but what do people want in providing it for them? So this was fully funded by the NIDA, and I'm just throwing that out there. It's not yet funded by a healthcare system, a payer, but it is a fully functioning mobile hub and spoke healthcare system, including it's the first legalized mobile retail pharmacy clinic in the whole United States, and it's right here in Connecticut. How did we know where to go and to do what we did? Well, we talked to the Department of Public Health, who are key collaborators, and they told us, why don't you start out in Waterbury? It's one of the highest, has highest rates of overdose deaths, significant risk of HIV, and the services, either there are deserts of services or people aren't being linked to services. So it required a lot of time before even initiating to going into the community, meeting with the mayor, local Department of Public Health groups, FQHCs, harm reduction providers, the people who lived there, so people who were living there, unhoused as well as housed, law enforcement, and then being able to move forward and go. So it is a really, literally a pharmacy. People always ask me this, so I'm trying to stress this. It's like CVS. It's not CVS, it's YNHH Pharmacy that we partnered with because they are a specialty pharmacy. It stocks all medications, including injectables as well as vaccines. This is Heather, the pharmacist, and can dispense in the moment long-acting PrEP, long-acting ART, hepatitis C treatment, et cetera. There's community healthcare workers, so they go out into the community. They're trained to do non-communicable testing, blood pressure checks, finger blood glucose sticks, rapid HIV Hep C testing, as well as substance use assessments and traditional assistance with other social needs, and have an iPad with a capability of doing telehealth wherever they are. So if there are people who don't want to leave where they're at, and can link with the mobile hub or any community clinic that you want to. We have medical technician who can draw blood, and a clinician, a fully APRN, as well as we have other clinicians who can do telehealth in person and go out into the street and meet people. I'm not going to go into this, but I just wanted to let you know that it was my first foray into legislation writing. But when we got this, I was like, let's go. And then was told, Sandy, no, the pharmacies are not legalized to become mobile in the state of Connecticut. So no pharmacy is going to work with you. So we quickly wrote legislation, and then we're able to get Senator Maroney to sponsor the bill. I testified, and then it was quickly passed and signed by Governor Lamont 1 year later, which includes SB 1102, and includes a whole bunch of other great things for pharmacists in the state of Connecticut that I didn't write, but I welcome you to read that bill. So for 16 months or so, we've been active. This is what the pharmacy looks like. It's a fully functioning clinic. We had to develop, it's seriously anything you could think about as a healthcare system, we had to do too. So we had to figure out how are we going to tell people where we're going to be besides flyers, if we had QR codes, and on that you can see a whole schedule, what services we provide, when we're going to be there. We had to provide instructions for clinicians to prescribe. So any clinician in the state of Connecticut can electronically prescribe to the pharmacy. We had to create a toll-free number. The system is directly linked with Epic, so our community healthcare workers register, get MRN numbers. The clinicians put notes into the Epic, so it's a fully functioning system. So some of the benefits, we've been able to reach close to 900 people as of a couple months ago, over 2,000 patient engagements, 1,000 appointments. Almost 50% identifying as women, 40% Hispanic, 23% Black, 42% unstably or unhoused, 30% uninsured, and 52% on Medicaid. We asked, how do they want to be seen? And I think this is a good point. Despite living through COVID, the majority want to be seen in person. They don't want telehealth. And what do they want to be seen for? Don't assume what people want, right? Primary medical care, pharmacy services, blood pressure checks, glucose screening. When we look at the medications that we've dispensed, now it's over 2,000 medications. Guess what? Main medications, cardiovascular, hypertension, diabetes, obviously antiretroviral therapy, PrEP, but I also wanted to point out, acute pain needs are also common. So thinking about pain interventions, other things we could be doing. We do work with the Dispensary of Hope. They partner with YNHH Pharmacy, and they're a philanthropic organization that provides free medications to people who are uninsured. So we are able to meet pretty much all medication needs for those who are uninsured as well. And guess what? Diabetes and hypertension, really the main players. Opioid use disorder, you got to remember, it's not a study, so they don't have to accept screening for substance use disorder, but we've been able to identify a lot of old opioid use disorder, new opioid use disorder, and be able to get people on opioid use disorder treatment, including buprenorphine, as well as provide naloxone. Alcohol use disorder, extended release naltrexone available, can do that. And then we're also assessing for stimulant use disorder. So great opportunity to provide contingency management. Hepatitis C, we do rapid point of care testing. We picked up a lot of previous diagnosis, able to do new testing, detectable viral load assessments, and then initiate treatment and cure. Remember, it's a fully functioning pharmacy, so you can, in the moment, dispense DAA treatment. HIV testing and treatment, we picked up one new diagnosis, 13 previous diagnoses, and we're able to test 313. And I think the other important point, we're getting people who are out of care, and those who wanted long-acting cabin relpivirine, we can provide in the moment on the mobile pharmacy. We assess for PrEP eligibility. The majority meet condomless sexual intercourse risk, but also assess for STIs and injection drug use risk. And again, we're able to assess if they want PrEP. Remember, not everybody thinks they need PrEP, but it is a reachable moment where we can continue to work with them. But we can also provide long-acting PrEP on the unit in the moment, as well as oral PrEP. This is just an article that was published on the early findings from the trial. And there's a lot of issues and challenges for feasibility and replicability if we're thinking about scaling this up, but it's a lot of work. And this is the implementation science that I think is so critical, is a lot of work talking to community members. We're thinking about, we've been to New Haven, Norwich, we're going to, and now going to expand to Bridgeport, and just thinking about what you need to do to keep this going. And it's a lot. There's been a lot of challenges. It's a clinic, so anyone who works in a clinic or, there's the challenges of that. There's a pharmacy, so there's a lot of challenges with the pharmacy services, inventory, securing meds. It's a vehicle, so gas, mobility, parking, repairs. It's regulated, so we have to be inspected and evaluated, and we need funding. So, right now is not a good time to be asking Yale School of Medicine and YNHH for money, although I have. We really have to be thinking this way is, yes, there are people who can reach our traditional healthcare systems, but there's quite a few who can't. And we really should be trying to figure out how to bring services, including whole person healthcare, to where people are. And I would say we can't really wait, right? We know that although overdoses nationally are going down, in the state of Connecticut, we're seeing substantial overdose spikes, plus other health challenges. Medicaid's going to be substantially reduced, so we have to be thinking about how we can help people. And, some of the barriers I think about, hey, we're going to these places that are identified by the Department of Public Health, like where overdoses are happening. We're providing everything, but not everybody's accessing or wants everything. Can we do better? And so these are heat maps from the Department of Public Health, circling in the left, people with HIV. In blue is where we've been going. So we are going to some of the hotspots. The right is overdoses. On this one, social deprivation index, again, similar, they all overlay in hepatitis C. And then this is diving down into Waterbury, and the purple areas are where the mobile pharmacy clinic has been going. And then the yellow is where overdose response sites have been identified by the Department of Public Health. And they have more detailed data, but can't share that for identification concerns. But, we're in some of these areas. And so what comes next is really, can we do a better job of identifying people, understanding what people really want? Do they really want services in those particular areas, or maybe they'd like them somewhere else? And then, really assessing from an implementation standpoint, continually modifying the intervention. So I won't really belabor this to leave time for questions, but really we've been thinking about this, about how to identify people and really provide better services. I've been talking to Greg Gonzalez. So Greg and David Klein at Wake Forest, Greg here at Yale School of Public Health, who do this amazing prediction modeling with collaboration with us, and then Mark McGovern at Stanford, trying to evaluate a better way to kind of develop this kind of better system. And I will end there. Obviously I'd be happy to work with implementation scientists here too, and others. We really can evaluate this system and do a better job. And I would say, we just wrote 2 grants about better lung cancer screening, head and neck cancer screening with this particular work. So there's all these other things that we could be doing to help this population. Want to thank the InMotion team, and everybody who's been involved with this across Yale New Haven Health Pharmacy and other programs, all of the state legislatures and governor and everybody, criminal legal system, community partners, lots of academic collaborators that all are not mentioned here. And just thank you for listening.
Thank you, Sandy. That's really fantastic. Multiple comments about just what incredible work you've done. And I really appreciate the way you've sort of flipped the script around people lost to follow up, people that are hard to reach, and noted that, well, the failure is not in those individuals, the failure is in the system.
Right.
And how do we change the system so that it works for
Right.
the people that are having trouble accessing bricks and mortar?
Absolutely.
So I just want to open it up. Are there questions? I have lots of questions, but I want to go ahead and let others share their questions before I jump in.
Maybe I should read some of them.
Mercedes Ditas Villanueva has asked, people who present to the pharmacy with HIV and not viral suppression,
Mm-hmm.
do you then communicate with their PCP?
Yeah,
How,
if they have one, yep. And the clinician, so you have to remember what people want. So some people are out of care, and it's the trust. They're coming to us, but they maybe don't want to even have medication yet. And but yes, if we look in the Epic system, we talk to the patient, we determine if they have a provider. And then obviously assessing whether we can talk to the provider. I think the great thing is, all the clinicians have to write notes in the Epic system. And the pharmacists also, any medications that are dispensed also go into the Epic system. But yeah, we definitely communicate. And then, it's not just, we're there maybe sometimes for a bridge, but sometimes it could be until the person's ready, that we have to keep going back, and that's also another challenge too.
Didas, did you have a follow-up to that? There's another question if you don't, but you turned your video on and wanted to give you a chance if you wanted to speak.
Yeah, I think some of us are very tied to bricks and mortar. That's what we've grown up with, and I wonder, how much of barriers we actually place because we're schooled in all of the prep work, not the prep, but preparation of someone, say for hepatitis C treatment or getting someone ready for HIV, kind of, reviewing their genotype and getting their insurance and all of these things. And when we want to do things, or with hepatitis C, like what has been tried before, and are the candidates for simplified treatment, all of that, is that totally circumvented by this mobile health unit, and is it, who are the right candidates for?
Yeah, so anyone can access this. I mean, originally the way I conceptualized it was I really wanted to reach populations who were mainly affected by substance use and at risk for HIV. But the point is that anyone can use it, and it also can be helpful for a provider who you have a patient, and they're having difficulty getting medications, blood work, or a check-in. You could link with the system. A community health worker could set up a telehealth video visit for you where they are. If you want them to get blood work or you want to talk to them about something, you can communicate with the provider or pharmacist. Again, one place a lot of people start is vaccines because they can't get vaccines and some of their things, and that's like an entree point. Because but other services, so anyone, and the clinicians are HIV experienced, as well as primary care experienced, and the family APRN, Annie Stevens, is could see children through adults as well, which is another area. Some people have brought their children on to get access to services. I would just say, yeah, anything you could think of. It's not meant to supersede any established service. It's meant to help get people into care how they want it, but also, bridge or to brick and mortar clinics if you can, of course. And we're just seeing there's quite a few people who can't or don't want to access traditional brick and mortar clinics. So, yeah.
So there's a couple of questions. Walter Kiernan followed up with on the question about the van, just asking who's funded it, maintenance and staffing.
NIDA.
It's a clinic. Okay, so NIDA funded
So
it.
yeah, no, it's so we started out, this is like fully funded by NIH. We did do a pro forma with Yale, with the business ventures, talked to Peggy McGovern, YNHH, Yale Medicine, and I think, this is what is absolutely needed. It can be an extension of Yale Medicine and Yale New Haven Hospital. We've had the hematologists, the cancer folks, other people who are realizing, this, it's not just infectious disease and substance use disorder. Anyone could really benefit from this. And so I would welcome collaborations and ideas on how to expand this into a more sustainable model. And I think one of the questions I always get though is, and I get it from YNHH too, is we have a lot of urgent clinics that are open now. They've expanded. Still remember, a lot of people still can't get access to those clinics, even though they might be open 24 hours. And there's still, as I just mentioned, many barriers to getting to those clinics. And so it's not trying to replace what's happening. All of our wonderful work we've been doing, but it's a way to kind of fill in gaps that could help bring more people into the system and integrate them more and help find people. And I think that's the kind of the message I'm trying to get across. And but yeah, no, it's got its own Epic build. You can bill for insurance, and then the beauty is for those who are uninsured, we can still see people who are uninsured and prescribe medications to them right in the moment. Yeah.
So I appreciate that, what I'm hearing is that you're creating a system that's a sort of a lower step up to bring people in, hopefully build trust, perhaps be able to link them to bricks and mortar. But if that doesn't work, they're still getting the services they need.
Yeah. And I think one of the things we have to think about, right, is all our wonderful interventions, our medications that we have. Let's think about GLP-1 inhibitors that, look awesome for everything under the sun, including substance use disorder, gambling, diabetes, real world, those, how are you going to ensure people are going to get access to them and receive them? Same is true for long-acting PrEP, lenacapavir every 6 months. You're going to need help, reminding people, antiretroviral therapy, long-acting buprenorphine. So I just think of, and this has happened to myself, if I book an appointment and I don't make it, I have to wait maybe another 6 months to come back. What if I was a person who wanted opioid use disorder treatment? I just completely lost my moment. And I think, we see a lot of people, say for HIV, we're talking about EHE, they might want HIV testing. They don't know where to go. And then say you get the testing. How do you get the, point of care we can do in 15 minutes, but if you do traditional testing, getting the results back, and then how are you going to get them on PrEP or ART? So we work with the Department of Public Health too. So if we have people for syphilis, TB, all of that, we can link with and help people who are still providing those services in the community. Again, I just want to stress, we're not trying to take over, we're trying to bridge and trying to help. And some people, this is the only access to services they can get. And I know we're about to end, but I'm so upset with what's happening with our healthcare system and losing Medicaid. If that happens, if we don't have funding, to be honest, I am really worried. Because I don't know how we're going to sustain. I have this through 2027, but I'd love to think about models of how to improve funding, because I think, there's going to be a lot of need.
Yep.
Beyond
There is one final question, if you can take it, that's just asking from Henry Lewin, that are the people coming to the clinic coming from the same neighborhoods? How do they get there? Are they walking? Are they driving? Are they using public transit?
Yeah, so these are all really good questions. So one of the things I tried, maybe didn't emphasize enough, is we don't expect people to just come to the unit. So the community healthcare workers who are they're the mobile spokes I talk about, going out into the community. To build trust, we worked with the Department of Public Health, local harm reduction service, going out into encampments, introducing us. So those are the touch points. We know we go to places where they're actively using drugs. Annie, our other clinicians go out. The community healthcare workers go out. So some are, coming up to the unit. Some are calling. Some are scanning the QR code and booking appointments. Providers are also doing that and booking for their patients. And then some are just word of mouth. So the key, which is your point of your question, which is one of the things we want to do better, and why I've been talking to really smart folks like Greg Gonzalez and David Klein and others, is how can we do a better job going to the places, even, you know, before there's any HIV known, or overdoses known, like, heck, is there a way to go? And then the qualitative boots on the ground research of what do people want? Where do they want them? Do they really want them in the same places that they're living? Maybe not. Maybe, maybe they want them somewhere else. And I would love to fund a heck of a lot more of these and a lot more community health workers and smaller units, because I think we're being asked to go everywhere, to be honest, and we can't. But this is where being integrated in a healthcare system like YNHH, which is trying to improve community engagement and work, and we already, you know, we can go across the state. You could be a linkage to the Yale New Haven health system, providing services where people are, including any advanced medications or treatments. So I think we're trying to do that now, is do that prediction kind of modeling work, hopefully with NIDA funding. So we'll see.
Well, thank you again. We really appreciate what you've shared. It's amazing work, and it's, you know, it is a beacon of hope and something for people to hold on to, and a really innovative model for people to work towards. So thank you very much.
Thank you. I appreciate it.
Let me stop the recording.